Good evening, everyone, and welcome to IR Bites. This evening's session is on prostate artery embolization. If you're watching this live, then I hope you enjoy it. But for those watching on catch up as well, if you watch over 80% of the content, you'll get a certificate at the end to evidence your attendance. I'll pass over now to Usman Mahe, who is an ST6 IR based in Birmingham. And he's going to be giving us the talk this evening on prostate artery embolization. So without further ado, Usman, if you'd like to take it away.
Sure. Thank you very much, Chris, for the invitation to teach on this great initiative, educational initiative set up by IR Juniors in going through the CERSI interventional radiology curriculum for medical students. So that's me, as Chris mentioned. I'm by no means an expert in this field. However, from my limited experience with senior colleagues and being involved in a number of cases and going through literature, I would like to present to you prostate artery embolization. As has already been mentioned, that this is the curriculum that we're trying to go through in this series of talks. This is developed by CERSI. So what is prostate artery embolization and what we're going to cover during this talk? Clinical presentation, including classification, imaging findings before intervention, IR treatment options, and clinical care and follow-up. It's the same format in the way they've done it through the curriculum. So, clinical presentation, including classification. Points to cover here. So, men with BPH present with lower urinary tract symptoms, which we'll cover in a bit more detail. And we'll go through the IPSS scoring system. Background-wise, anatomy. So, the prostate is a walnut-sized organ at the base of the urinary bladder. So we've got the bladder here. And the anatomical illustrations date back to the 16th century. It's just a bit of history there. In terms of anatomically describing the prostate, it was initially thought to be in lobes, but however, this could not be defined by dissection. And so the McNeil classification in 3 distinct areas into non-glandular fibromuscular stroma and 2 glandular regions were developed and is currently used in practice. I'd like to mention the central zone there and peripheral zone, but our area of focus is predominantly on the transitional zone, which is around the urethra. It's only a small part of the prostate, approximately 5% to even 10% in some places, it says. And why is that important? It's the principal site for benign prostatic hyperplasia. So nodular expansion occurs, it compresses the urethra and results in bladder obstruction, which is often partial, and that's why they present, but can also present with urinary retention. In terms of histology and gross anatomy, we can see that the transitional zone here is nodular enlargement of the transitional zone. This correlates on histological side. In terms of terminology, yes, it might seem a bit pedantic, but it's quite important to cover. So benign prostatic hyperplasia is a histological diagnosis. What was seen in clinic is benign prostatic enlargement. There is this other small entity, which, again, it's probably a little bit sketchy, but essentially is benign prostatic obstruction, which means that the prostate is not enlarged, but they are still experiencing symptoms. So what happens in BPH, as we just touched on it briefly, nodular, multinodular involvement, and adenomata. So an adenoma itself is a benign growth, a non-malignant growth. And you can see from this illustration that where the benign growths and where prostatic enlargement happens, it can result in obstruction of the urethra, resulting in the symptoms. I've mentioned dynamic in terms of the prostate smooth muscle and the tension, because some of the medical therapies are based on that. With regards to age, BPH is common. So on autopsy data, about 50 to 60% of patients who are in their 60s have BPH. And this increases when patients go into their 70s, where around 80 to 90% of people or men who have benign prostatic hyperplasia. Again, this is what we're focusing on, bladder outlet obstruction, and we'll go through some of the symptoms which relate to bladder outlet obstruction and where prostate artery embolization has a role. Again, as it's a sort of focus on the medical student curriculum, we just go through basics of presentation. When a patient presents, we take a history, we go through some investigations and management. So how do these patients present? Well, they'll present initially to the general practitioner and refer to urologist. And if they do require interventional radiology, therapy, they'll be then referred to us. I just wanted to emphasize on this point that multidisciplinary team approach is very important here. PAE is one of the options where used in management of BPH. It's not the sole and exclusive option, but it's one of many options that are available, and therefore a multidisciplinary team approach is of importance. So lower urinary tract symptoms, just briefly, I've just put it down as LUTS. So we've got storage symptoms. I've put down fun is one way to remember. It's not actually fun for the patient. So they can experience frequency, urgency, and nocturia. And then we've also got voiding symptoms here. So hesitancy, intermittent urinary stream, and terminal bladder dribbling. So this term here, prostatism, is quite an old term. What we just refer to these group of symptoms is pretty much just known as LUTS now. The IPSS, it's of urinary symptoms. So it's 7 questions. Each one is a scoring of 0 to 5 and a maximum points of 35. This broad classification of them into mild, moderate, and severe, it's quite broad, been set up in a way which it's accepted now. This is an example of the IPSS scoring system. So I'll give you a brief moment to go through that. But essentially, bladder outlet obstruction. So the storage symptoms we mentioned are frequency, urgency, and nocturia. And so the voiding symptoms are pretty much the rest of the symptoms there. And again, those are the voiding symptoms is where patients, experiencing bladder outlet obstruction. So this is scored out of 35 and classified as mild, moderate, or severe. And that reason that is important is because PAE is often, or treatment for BPH is warranted for patients who, or considered, should be considered by patients, as a collective decision for patients who have moderate to severe scoring system. There is also an additional question on quality of life due to the urinary symptoms. I'm not sure how this Likert scale came about, but essentially means if they're delighted, down to terrible. There is also an IIEF, International Index of Erectile Function, and then I've put there beside it IIEF 5, because now a compact 5-question with regards to erectile function here. I mean, they're quite intimate questions, and again, the IPSS is, compliance, but the response rate to that is probably more accurate. With regards to the IIEF, again, it's a bit more intimate questions, but it is of use. Clinical examination, so often seen by a GP or urologist. They may have a palpable bladder from bladder outlet obstruction. The role for the digital rectal examination, is to look for whether it's a benign feeling, smooth prostate, or is there irregularity or nodularity that might be concerning for cancer. Blood tests which can be done, things like renal function to investigate other causes of LUTS, and the PSA could be elevated, but is not specific. Furthermore, urodynamics or flow studies can also be performed, which will help in patient selection. So now moving swiftly on to imaging, as it's a talk on interventional radiology, and then the radiology bit is something that we've got to deeply understand, and plays a huge role in identifying suitable patients for PAE. So the points on the curriculum, which we're just going to cover here, imaging modalities include ultrasound and MRI to determine gland size and lack of malignant features. MRA or CTA helps assess the variable prostatic vessel anatomy before the procedure. So each in turn, ultrasound, it's a quick examination, can be done in the clinic, doesn't involve radiation. You can get a volume measurement, you can use a calculator. Anything greater than 30 mils is usually considered as an enlarged prostate. Why do we do MRI? Well, it's to further evaluate, particularly in those patients where they have risk factors for malignancy, and you want to rule out cancer. It's a better investigation. It doesn't have any radiation. However, it's longer. MRI sequences can take longer, can be quite uncomfortable for some of the patients, particularly with a scanner being quite noisy. Contraindications is just this sort of image of, putting metal by a magnet doesn't work. So again, there'll be some patients who cannot have an MRI scan for a particular reason. However, it does allow you to assess volume quite accurately. Ultrasound is very operator dependent and can be quite subjective. And also the role for cancer is also there. So an important tool in a workup of a patient with a BPH or working up for PAE. This is an MRI picture of BPH, and we've got axial, sagittal, and coronal T2 slices, which show an enlarged prostate. As you can see, the median lobe is going up into the bladder. In fact, this patient with this median lobe sort of abutment of the bladder may not necessarily be suitable for PAE, but the features here just are benign prostatic hyperplasia on imaging. And again, it's pretty much not showing, well, there's no malignant features. And again, that's probably where the role of MRI lies. With regards to computed tomography angiography, CTA, it's important. And why is it important? In terms of planning, it's basically a donut, as some may call it. And that's why I've got that there. So it does involve radiation. However, it's relatively quick, but it does allow good demonstration of vascular anatomy. You could arguably calculate a volume from the CTA, but main thing here is vascular anatomy. And the prostate artery is very small. You're talking literally 1 millimeter, 2 millimeters. And for us to see it better on a CTA imaging, we can give a bit of GTN, which will dilate the vessels and allow them to manifest better on a CT scan and an aid for planning. So why else is a CTA important? You can plan for access, how you're going to plan the procedure. You look for atheroma that may preclude you from getting to the prostate artery, and a patient therefore may not be suitable for a prostate artery embolization. I can't emphasize this point enough, in the sense that it's very important to look for the anatomy. I put conventional in inverted commas, and we will later cover prostate artery anatomy and the various types that exist. And so we've got to be careful of variance. So essentially, it's a very important planning tool. Here's an example of a CTA. So we can see that we're trying to get to these small arteries that are absolutely tiny. And in this particular case here, you can see that there's some atheroma near the origin. Again, it's something that is very useful for planning. And at this point, a patient may also not be suitable for PEA, and then it's not so you save that step from them attending on the day or trying to cannulate a very difficult, or trying to get access to a very tiny prostate artery. So it's very important in the terms of planning. So with regards to IR treatment options, well, there's prostate artery embolization. However, again, like I said, it's just one selective embolization of prostatic arteries with small particles, efficacy approximately 80%. And again, that's from the point on the curriculum from CERSI. I'm just going to go into a little bit more detail in terms of treatment options in general for BPH, which, although remains the remit of urology, but it's still important to consider. Again, like I said, is an MDT approach. So medical, so simple medication, as we mentioned earlier, can be given to patients, see how they get on. There are surgical options, again, remit of urologists. It's TURP, transurethral resection of the prostate. It's an invasive procedure. There are, however, less invasive surgical procedures, resume urolift and aquablation, which I also mentioned. However, given all that, we would still consider the IR option to be minimally invasive, and that being prostate artery embolization. So this is what people think of radiologists. I'm not sure how much the experience the audience has had with or dealing with a radiology department or understand what radiology do, but they might think there's somebody sitting in a dark room looking at plain films. However, or they may think we do this and have a bit of fun with the kit. But essentially, interventional radiology is a very clinical specialty. We find ourselves in a theatre-type environment with an angio suite, sterile equipment, sterile, everything's done in a sterile fashion. But fancy technology, it's very much a clinical specialty and can offer treatments for various conditions. Just a brief history of PAE. It's a relatively new treatment, if you think about it, since early 2000, so it's only within this century. And the therapeutic effect was first described around 2000 by this paper back in JBIR. That then followed on with some animal studies. There's a couple of papers here which showed animal studies. But the first human treatment, which was intentional for PAE as a primary treatment for benign prostatic hyperplasia, was described in 2010, so not that long. The evidence is, however, growing. It's because it's a safe and effective procedure, and there is a lot of work that has gone on over the years describing, and these are some of the studies or papers, into further So I'm just going to keep it brief, but the evidence is getting strong, it's building, and there's still a lot of work to do and a lot of things that we can learn about prostate artery embolization. There's some more, and a lot more work is going on. Again, like I said, there's far more people experienced in research out there and have done some great work with regards to prostate artery embolization research. PAE versus other options. There's some of the stuff we can take. It's a safe and effective procedure. It has a similar IPSS reduction compared with TURP. It's non-inferior. Where it basically is useful is ejaculatory dysfunction, where PAE described as having less dysfunction, and similarly less bleeding or a lower bleeding risk, and definitely a short stay with regards to hospital. So it's a safe and effective procedure which has been in the UK approved by NICE since 2018. We've also got a CERSI standards of practice on prostatic artery embolization, which is from 2020, and we've also got a multi-society consensus position statement on PAE, which is quite important. These three are quite important references to be aware of, and cover a lot of the evidence base up to the point of their publication. Just a little bit of focus on patient selection and considerations. PAE is not necessarily suitable for all patients with BPH. And like I said, I'm just going to re-emphasize it is one of the options, and an MDT approach is quite important. With prostate volumes about 30 to 50 mils, it could be said, TRUP and surgical treatment is very good for that. However, when you're going to higher volumes, particularly towards 100 mark, then PAE certainly has a role with regards to that. Again, failed medical therapy. When patients are suffering from urine retention, or they're dependent on catheters, and patients, ultimately refusing surgery. There's quite a long list. I don't want to sort of go into too much details of them, but they're there. And, we have to also accept that the surgical interventions, whether it be invasive or minimally invasive, still have a role. With regards to relative contraindications of PAE, then we just touched on it before: atherosclerosis, very difficult to get into the vessel, very difficult access, which may preclude the procedure and therefore can't go ahead. Other things are bladder diverticular size. If they're greater than 2 centimeters, that's bladder diverticular. You get these outpouchings of the bladder from chronic, bladder outlet obstruction. And this little point here where you just got to be a bit more cautious. Although the PSA is quite non-specific, but the patient may have to have further workup with regards to MRI and prostate biopsies before proceeding with PAE. So consent is very important, and it is done by the urologist or referred to the IR. Options should be put forward to the patient, and including doing nothing. The benefits are, the benefits of prostate artery embolization is to reduce the volume size and to release some of the pressure on the urethra. Again, hopefully with improvement in bladder outlet obstructive or symptoms. In general, risks, these are general risks for an IR procedure and a vascular procedure, is pain, although they're done under local anesthetic and most patients tolerate that fine. Infection risk is there, again, minimal, but because we're working through a minimally invasive we're using a minimally invasive technique with only a small incision, if that, and at the access site. Bleeding remains a risk from any access site, and that's well known. Specific risks with regards to PAE, non-target embolization, and that's where some of the symptoms or the complications or adverse effects of PAE can take place. You've got to be careful about where the prostate artery may anastomose to, where it's arising from, where it's leading to, in case you have reflux of embolic agents into vessels, and with regards to associated adverse effects, whether it be to a rectal branch or whether it's going to a penile branch. Again, they can experience, or similar vesicles. You may have hematospermia, but again, those are things which may be related to non-target embolization, and it's very, very important to have that clear on when consenting a patient. Post-embolization syndrome lasts a few days, not very long. Patient might feel mild fever, nausea, vomiting. And this is also important as technical failure. May not be able to still get into, despite all that planning, may still not be able to get into the prostate artery. Radiation, I mentioned that there. It can be quite a high risk, or not high risk. It can be a high dose procedure relatively compared to other procedures, but again, operator experience as times reduce and access and planning go forward, again, those risks come down quite significantly. So technique. So with any IR procedure, or I like to think of it as the 3 S's, and that's how I see it myself, is how we're going to start. You're going to plan your access. Are we going to go through a femoral artery, radial artery? Again, important to plan where we're going to start. Steering. Then we go back to the CTA to see in what planes we need to, in fluoroscopy, can we turn it oblique, ipsilateral by 30, 40 degrees, cranial caudal angle again, but then also looking at the vascular anatomy and what catheters, wires are we going to use to steer our way to the prostate arteries before we can embolize the prostate arteries. And finally, closure and follow-up. How are we going to close that vessel? It's very important. Again, planning is very important in such procedures. I know it's a bit of an overwhelming slide, but prostate artery anatomy, in basic terms, you've got the aorta, common iliacs, you've got internal iliacs, you've got the external iliac off to the leg. But essentially, it's a branch coming from the internal iliac, to put it in the basic terms. We've got the PAE coming here, that's a superior vesical artery, and it's important to recognize other arteries around it before you recognize a prostate artery. Things like the obturator artery is important, internal pudendal artery is important, and superior gluteal and the superior vesical artery. So knowing anatomy of other vessels allow you then better identification of the prostate artery. As you can see, it has variant origins. So here it's coming off the here it's coming directly off the internal iliac. Again, they're classified into these 5 types. Coming off the obturator, again, coming off the internal pudendal, and you've got an accessory vessel there where it could also be arising from. So again, go back to the CTA and planning. But essentially, to keep it simple, is the branching pattern of what you really need to know in terms or as a foundation level, is that it's a branch of the internal iliac. And then if you do wish, you can go in and learn more about the anatomy and bloods, the associated branches. I haven't really gone into other things in terms of you've got prostate artery. Well, you've got prostate arteries on both sides usually. However, there may be a crossing branch which connects both sides together, and that will be important at the time of procedure. Again, you've got to look for catheter placement and positioning to avoid any non-target embolization. So planning is key. But I hope this does make sense. I've left it up there, particularly for a little while longer, so you can appreciate the variant anatomy that you may come, that may come your way. Where to access? Femoral is a familiar approach, less tolerated by patients. You can imagine, they're having something in their groin, dignity, and also in terms of having manual compression at the end on the groin and lying flat. All those things put together, despite the advent of closure devices, it's still, somewhat less tolerated by patients. Radial artery, better tolerated by patients. You go from the wrist, it's easier in obese patients, but you're limited by kit. And sometimes you're limited by the vessel itself. You want to have the vessel to be a couple of millimeters at least before you access. Another thing which I've just mentioned here with a question mark in terms of starting is related to PAE, whether the placement of urinary catheter. Some experienced operators will say you don't need it because they've planned it well and they think the procedure is going to be relatively done in a timely fashion where the patient doesn't need to empty the bladder. Then it can be avoided. But in some cases, the urinary catheter will need to be placed. But again, it's not something pleasant to the patient usually. So access-wise, this is a small revision about a slide on Saldinger technique. Who was Saldinger? British interventional radiologist. I've put interventional radiologist there. Who first described the technique in 1953. Some people talk about Dotter and in intervention, but the Saldinger technique was 1953. So we're going back a long time, and that technique is still used, or modified in current day practice. What does it involve? So initially, you're going to get a sharp needle into a vessel. So let's just take this. We're going retrograde access into the common femoral artery. Retrograde meaning against the flow. We put a needle in. You get some blood back. You can insert a wire into the vessel. The needle then comes out, and over that you can put a sheath and a tube. Just an example of an access needle. And you can also, if you're going into, for example, radial, you could use a smaller needle and a micropuncture accessor with a thinner wire. Examples of sheaths: smaller sheaths used for radial access. You've got more conventional sheaths, which you can use for femoral access. But essentially, it's a sheath. Once you've got stable access, with blunt-ended, you've got the port there. You can flush it, keep it regularly flushed, and inject contrast, and etc. And then through the hub at the back, you can pass your catheter and wire. Steering. So this is an angiogram. Here we've got the aorta. It splits into common iliac arteries, and then going into external and internal branches there. So how are we going to get there? So if you're accessing into the common femoral artery, which ideally around the level of femoral head, so it helps with manual compression at the end, you need to go up. Getting into the same side can be challenging, and similarly going across. And again, that comes to the importance of planning and what catheters are you going to use. Various shapes and sizes of catheters, and this is just a brief example of them there. Wires. Again, wires come with different, built on basically on different technology. So you get hydrophilic, softer wires, you get stiffer exchange wires, you can get micro wires. Again, there's so much kit out there, but that also makes it specialty quite exciting and a skillful specialty in terms of navigating to the target vessel. To get over the arch, a commonly used catheter is the rim catheter, but because the prostate artery is tiny, it's a couple of millimeters, you often need a microcatheter to go within a sort of what we call a parent or mother catheter to get to your target vessel. But again, those are details. At this point, it's very useful to know the variety of kit or a number of catheters which are available and which can allow you to get to your access point. Here's a diagram of the internal iliac artery there. Loosely, you could divide it into an anterior and posterior trunk. But again, like I said, that's quite loosely. So we've got the branches coming off, but essentially we've got over, you get a macro catheter off up to that point, and then you can take specific or dedicated angiography imaging from there to plan further ahead. Going back, so once we've come around to that point, we need to then get into the prostate artery. And that's where you have a role of a microcatheter. Here's the IVA, which is referred to in this particular articles as a prostate artery. You can inject a vasodilator into it for you to dilate it, for it to be better seen and allow for much more distal access into the vessel. If you can appreciate this, you've got a parent catheter and stuff, but you've got this thinner microcatheter going in, and this is where the prostate artery has been cannulated. And once contrast has been injected into the gland, you can see the right hemiprostate with its intense contrast blush or light up on this particular modality. So once you've got there into the prostate artery using a parent catheter or mother catheter, and then a microcatheter and a soft wire in there. Be very careful that you don't that the wire could result in the vessel going into spasm. But again, it's very important to know what you're embolizing prior to administrating embolic agents. It's very important to pause, stop, really check and hone in onto what which vessel you're actually embolizing. So here is some more technology. So within the procedure, you can use CT technology, but in the angio suite, you can use cone beam CT, and you can see how with contrast injection, you can see that you are into a target vessel. But the main thing what you're looking here for is you're looking for any branches which are going down to the rectum or elsewhere, and you're looking for any variant anatomy or anastomosis to another vessel prior to embolization. Embolic agents. So what do we use? So there are many embolic agents out there. You've got temporary agents, you've got more permanent, more permanent agents, which can either be in liquid. You've got plugs, coils. A lot of people see coils, the metallic spring. You see them. A lot of this stuff you don't really particularly see. Our particular focus of attention is here, is particles. As it's a gland, you want to get deep into the gland. In order to shrink the gland is for it to have sufficient angionecrosis or the necrosis of the gland and infarction of the gland for it to reduce in size. So you really ideally want to use particles to go to get that deep glandular embolization. Again, just a bit of a syringe and how we prepare it. It might come in a larger vial. Just use these sort of non-branded syringes here, but you prepare it and you agitate it, and this is again a diagram of what particles are, but they're small. The key thing is small. And what size do we then use? So before we touch on that, we'll go back. It's a familiar slide in terms of where your catheter is, what spheres you're going to use, and and how they work with regards to particles. But now PVA embospheres, as in spherical part, are used now more commonly in prostate artery embolization. With regards to size, again, different operators have different views on this. From what I've come across, but some may say you want to have a combination of microns for the smaller spheres to go in deep into the gland again, and then also the larger ones for other parts of the vessel. Essentially, the main idea of is stasis. You want to get it bilaterally. You may find that from one side that there's cross-filling and you have cover majority of the prostate, and it might not be technically feasible or able to get into the other side. So again, you do want to get as much stasis as possible, and that's where these are more advanced techniques come in. So you've got the perfected techniques. So you have proximal embolization first, and then embolize distally. You've got coil embolization. If there's a variant anatomy and there's a different anastomosis, and you want to protect that, or you want to avoid non-target embolization, you can use some of these techniques. So here we go. So we got a microcatheter into the gland. So you can see that you give this is part of the perfected technique. So proximal embolic microsphere injection, and then followed by a bit more selective or distal embolization. And this is what you want to get to. You want to have true flow stasis. You want to, it may be very challenging to get in there, so it's very important that you get adequate stasis, and again resulting in appropriate angionecrosis and infarction to reduce that volume and have symptomatic relief from the procedure. Here's some imaging of a gland you can see these intense blush of the glands or prostate artery on each side pre-embolization. It's difficult to appreciate, but we got post embolization. You can see less of the gland there, and that's stasis in terms of the flow. So hopefully picture it better in a more magged up view here. So we've got the left prostate artery, you've got this intense blush there. You can see how it's been embolized and there's no longer flow to it. So it's very, very important to get adequate or true stasis to the prostate. So how do we end, or how do we stop and close the case? So if we've gone in either radially or femorally, well, femorally you can apply manual compression. With regards to radial access, there are various bands that you can apply, a TR band or a safeguard, whatever. It's basically a compression band applied around the wrist, and which will allow early mobilization. You could opt for an occlusion device, although prostate artery embolization could potentially be performed from a very small sheath size where manual compression is sufficient. I've put antibiotics here, so it's important to complete a short course of antibiotics, usually ciprofloxacin from my experience or limited experience, and that's to again prevent any UTIs developing. So clinical care and follow-up. So looking at clinical care and follow-up is just a brief point which I'm going to touch on. So prostate artery embolization typically formed as an outpatient procedure, so that it can be done as day case. So versus a surgical intervention where overnight stay is required, the increased risk of bleeding. Again, this can be turned around for the patient as potentially as a day case. The symptoms improve within several months. You've got to give it time for it to work. Early follow-up, initially at 3 months, is just to see how the patients got over the procedure, whether they experienced any early side effects, adverse effects, complications, or post-embolization syndrome. How are we going to follow them up? We started with imaging. You could follow up with imaging, but does that make much sense? I mean, if you've reduced the prostate volume, how does that correlate? Ultimately, the patient presented with symptoms. So it's very important later on, maybe 6 months or even 12 months, is to repeat the IPSS questionnaire and the IIEF-5 questionnaire if you can. Get that with patients to complete that in order to see if your procedure has worked. And so clinical follow-up is important, and particularly of symptoms. And so that also then goes back to, in terms of patient selection, make sure your patients are adequately worked up. You've selected the patients who are most likely to benefit from the procedure. That's it in summary. In terms of I've just put this slide in here. So interventional radiology has a role in men's health, particularly with prostate artery embolization, which we've covered in this session. Testicular vein embolization is another procedure related to IR in men's health, and which we will try and hopefully cover in a later session. I'd like to take this opportunity again to thank IR Juniors for allowing me to, or inviting me to present. Thank you.
Yeah, thank you. Thank you so much. We'll just have a look at the questions dropped in the chat. There was just one or two. So the first one from Darren Maloney was regarding ultrasound for prostate. So just to clarify whether that's abdominal ultrasound or transrectal. And then the second question was from Mohammed, who's asked whether we should be embolizing both branches of the prostate artery, or is one enough?
In terms of the first question, is that abdominal or transrectal ultrasound? Well, again, it depends on patient body habitus. It's a very operant examination. If you can get good views on abdominal ultrasound, the benefit of transrectal ultrasound is that biopsies can be performed at the same time. So again, it will vary on patient. With regards to embolizing both branches of prostate arteries, or one branch is enough, that's a very good question. Speaking to senior colleagues and having limited experience, it's very important that you try and embolize both branches, or both prostate arteries on each side to get adequate stasis. Having said that, only one branch or one side may be enough if there's cross-filling. You might get a branch going across both hemiprostates, which will then hopefully allow again, that's where cone beam CT may come in. So you may go into one side and you see actually it's covering a large amount of the prostate, and that's where one may be enough. So again, it goes back to planning your procedure. It goes to the use of intra-procedural cone beam CT and see how much coverage of the prostate you're getting. But ideally, yes, you want to cover sides.
Do you prefer to inject verapamil prior to embolization for better stasis, or just the PVA spheres?
I've not seen verapamil used, but again, like I said, it's very limited experience that I have. I've not seen verapamil be used prior to embolization for better stasis, but I've seen adequate stasis achieved with PVA spheres, and again using some of the advanced techniques, particularly with regards to perfected, to get good amount of stasis.
I hope that answers the question. Thank you again, Usman. Apologies for the delayed start, everyone, and for the slight technical issues, but I think we powered on through. Just one last question.
Yeah,
we'll round it off.
Sure.
So is there a role for PE in other than BPH? So, for example, for prostate cancer.
Again, it's a very good question. A work in progress. Whether you can sort of translate that into chemoembolization, but yeah, we hope that there will be a increasing role in management of prostate cancer. But again, at the moment, my understanding that PAE, in terms of how it's licensed and available as a treatment option, is reserved for BPH. Although it was performed back in the time, prior to that, in terms of bleeding, you'd still do it as bleeding. But hopefully there will be a role in terms of, and it will hopefully form a part of management of prostate cancer. But again, watch your space.
Yeah, I think that kind of emphasizes the importance of ongoing research. Really, we can postulate that potentially it will be very beneficial for prostate cancer, as we're seeing with more evidence coming out to say that for BPH it's potentially better in many ways than traditional approach, which is transurethral resection of prostate. So this shows that IR is still a relatively new field, particularly with the oncological interventions. So it's quite exciting for IR juniors to be going into a field that is changing quite rapidly. Cool. We'll round off there. Thank you everyone for watching. Please feel free to watch the other episodes on Catch Up, and there are 7 more episodes yet to come at the very least. So please tune in for those ones as well.